So in summary of last weekend, we talked about the rule of threes in the thoracic spine. This is where it describes the average obliquity of the spinous processes in relation to the vertebra. So for the first three, it is level with its own bone. So T1 is level with T1, T2, T3 and so on. The second group of three, they're more oblique and they are level with the disc below their vertebra. The third group of three, they're more oblique still, and these are now level with the vertebra below their vertebra. And then the last three reverse the trend. So T10 is level with T11, T11 is level with the disc of T11-12, and T12 is level with itself. You need this rule of threes to know exactly where you are in the spine. But as I said to you, you're better off counting your level in the spine by counting the transverse processes, which are generally easy to palpate, even if they're not rotated. We talked about doing PAs in the thoracic spine, taking into account the obliquity of the spinous process. And I said that you're better off putting the pads of your index and middle fingers over the transverse processes and then pushing down through those fingers. That way you know it's going anterior and not extending when you do so. Contraindications to thoracic manipulations. Bleeders is a big one. The spinal canal is small compared to the contents and the caliber of the canal. So any blood in there is not only toxic to the contents, but there's more pressure applied to it for a smaller amount of blood. So stay away from people who are on anticoagulants, whether it's long-term like with atrioventricular fibrillation or post-surgical or anything else. Stay away from bleeders. Osteoporosis, the ribs are particularly fragile when this happens, and of course be careful that you're not manipulating the spine for viscera. Other than that, all the usual stuff applies, disc herniations and so on. We talked about coupled spinal movements in the lumbar spine, and as I said to you, that basically don't take anything you read as being definitive. Pretty much every major authority on this gives a different opinion to every other major authority on this. So this is like a religion, pick your belief, but don't stick to it. And also remember that you're dealing with dysfunctional segments, so there's no reason to expect that to conform to normal, even if you knew what normal was. We looked at a case of a laminar sprain in a 14-year-old boy. This is a torsional injury, so soccer is a big one because of kicking. And then we talked about lumbar symmetrical and asymmetrical dysfunctions, and how symmetrical dysfunctions won't show up on position testing. So we went through the symmetrical P-PIVMs to determine whether there is a hypomobility present, and that video is in the general videos on my YouTube channel. We also talked about the thoracic exam, both diagnostic and biomechanical, and the big one with the diagnostic exam is you've got to remember the viscera. You have heart, which is actually relatively common source of pain, lungs, pleura, esophagus, trachea. All of these have pain receptors, and so all can produce thoracic pain. So be careful of that. Probably your best bet is if you're getting negative PAs, and when I say negative, I mean they're not appropriate for the pain the patient's complaining of. It'll be much lower than it will be if it's referred than the pain actually is. It may be some still there because of segmental facilitation, and also the fact they may well have a thoracic dysfunction, but it's going to be a different pain to one they're complaining of, either in intensity or in quality. We looked at the posterior-anterior manip with the patient prone and manipulating with the hypothenar eminences, and there's a video on that somewhere. I don't think you've got that, but I'll get this to you. I think Mo took it, but didn't give it to me. Then we looked at case 2, which was severe central and right chest wall pain at about T9-11 in a 28-year-old man. and we talked about whether it could be visceral or whether it could be locomotor. We also discussed the sacroiliac joint, both the P-PIVM and the biomechanics, and we talked about how the osteopaths had 3 axes for flexion and extension, whereas in fact you only need 1, and that's a transverse axis around which it can rotate. And then we talked about the oblique axis, which I maintain are dysfunctional axes, where one joint is flexing or extending more than the other one, and it's causing the sacrum to rotate around that dysfunctional axis in much the same way, in fact in exactly the same way as occurs in the lumbar spine. So you get these positional changes in flexion or extension. The P-PIVM for this, from the sacral perspective, was pushing on the superior sacral areas to flex that side, or on the pressing on the contralateral inferior area of the cornu to extend the opposite side. From the front, we did anterior and posterior rotation or extension and flexion respectively, and we also looked at medial and lateral rotation or inflaring and outflaring respectively. In the lumbar spine, we looked at 4 manipulations, 2 pelvis up and 2 pelvis down manipulations for both flexion and extension, and you got videos on those too. Then we talked about an outlier biomechanical dysfunction case that looked like initially a disc herniation, an uncontained disc herniation, which then had negative straight leg raises, so then it looked like a contained herniation, but was in fact an atypical outlying biomechanical dysfunction, and the difficulty in trying to sort that out. And in the other case, we looked at a central stenosis in a 22-year-old, which is another big outlier, of course. And what I would have thought initially on this was that it was a spondylolisthesis, which, when turned out to be wrong, leaves you with central stenosis, and possibly this is a congenital defect in this patient. If there was trauma before he actually fractured the vertebra, this could be excessive callus formation around it. So as far as I can remember, this summarizes everything we did last weekend. If there's anything else, let me know.